This is a chance. I think it's probably a little different than the normal rounds, but that's okay. Thanks for indulging me. I'll be talking about the biomechanics of chronic low back pain, movement phenotypes, patient-reported outcome correlations, and a potential road to predicting treatment outcomes. I'm a professor of mechanical engineering at Brigham Young University. My PhD is in bioengineering. My research is in spine biomechanics and medical device design. So I won't spend a lot of time on motivation and context because I think most of you are aware of it. But if you haven't had a chance to peruse the global burden of disease study that was published in Lancet Rheumatology last year, you really should. It gives kind of a highlight and an exclamation point to why low back pain is such a big deal. 1 in 10 of you is experiencing low back pain right now. That's the statistics. So that's not good. In our lab, specifically over the last 5 years, we've been looking at kind of this correlation between the biopsychosocial well-being and how we move, especially how we move our spine, and doing some quantitative analysis of that, and specifically identifying movement phenotypes, ways that people move that are indicative of what maybe the underlying problem might be, how they group together in kind of phenotypes or ways of moving. And the intent here really is to identify, underlying pain generators based on the way that we move, incorporating biomechanics into that, as well as identifying optimal interventions based on the way that people move, and then tracking improvements of those. So this project that I've been involved in for the last 5 years is part of the NIH back pain consortium called BACPAC. And specifically, our project was to develop and validate an inexpensive wearable sensor array for measuring segmental spine biomechanics, and then use that to identify biomechanical phenotypes associated with chronic low back pain, and also a matching cohort of healthy control subjects, since that data currently was missing as well. And I'm going to be talking about not the first can it work part of this, but the how has it worked part of this. To give you a sense, this is a wearable device. It's about $8 in parts. Runs on a smartphone app in the Google Play Store. It takes about 15 minutes of technician time in the clinic to collect this data. That app connects via Bluetooth with the device, uploads that data to the cloud to Amazon Web Services, where then machine learning analyzes the data, and eventually we'll send the data right back to the app on the smartphone, so the clinician has real-time kind of, this is how I might move forward with that. And I'll give you, this is just kind of a sense as to how the device is put on. One of my colleagues, Rika Mitchell, putting this on, actually it's on her husband, who's also a physical therapist. Sorry, I misidentified her husband. He helped with some of the videos. This is actually somebody else. But goes through a series of exercises. Each one of those exercises, you can kind of see the dashboard on the app is just asking kind of how to do that. You go through each exercise 6 times, and then that data is then uploaded to the cloud. And I'm not going to make you watch all the repetitions of that, but just kind of where we are to date. So with our BYU study, we've recruited 290 out of our 300 subjects, and the other 10 are all scheduled for completion here. So we should be done in the next couple of weeks with accumulating all of that data. You can see it's a pretty well-matched cohort of individuals. What's been exciting for us is not just the 300 folks at BYU, but it's that it's gained pretty broad acceptance as well throughout this back pain consortium. So we've now had over 1,300 of these spine sensor arrays built by students, which is kind of awesome at BYU, that they've been manufactured, calibrated, packaged, and sent out across the nation. We've had 15 sites nationwide participating in using this. BYU, there's 12 sites that are part of a large NIH-funded clinical trial. And then there's 2 local clinic sites that have been helping as well. It's been used by over 40 clinicians and technicians. And then there's 4 other additional clinical studies that are using it. So we're pretty excited about this. These are the exercises that the subjects that once they get it on are going through. It's 6 repetitions of each of these motions. And then they also complete a series of patient-reported outcomes, a pretty comprehensive barrage of questions about kind of their current spine status, as well as collecting demographics and other information from them. We also have MRI imaging for all of these subjects as well. And just to kind of start sharing some of the things we've learned. This is kind of probably what you anticipated if you differentiate between the chronic low back pain and the control subjects, that there's significant differences all across the board, with one exception, and that one I think is really interesting. Let's see here. And that would be on their activity level. That was a little surprising to us. There's absolutely no correlation between chronic low back pain and activity level. It turns out that high-functioning chronic low back pain folks are the ones who volunteer for studies, and they're more likely to be involved in the study. There's a lot of data that shows that. But also just the fact that people with pain are engaged in physical activity is something we should be aware of. Sometimes we categorize them with a little stereotype, and that seemed to not be true at all for the cohort of folks we had. This is just a look at demographics. Not a lot that's strong here, but a few key points to point out. One of them is that getting a high education is overall correlated very well with lower pain intensity, lower ODI, and lower promise and higher promise physical function. So go to school. That's interesting, and I have no idea why that's the case. The second is that opioid use had a strong correlation with higher ODI, lower physical function, and higher pain interference. I think that's probably an expected correlation. The reported physical activity, so the IPAC, like the patient saying, how much did I actually engage in activity, had strong correlations with the promise physical function, which is kind of a how well can I move, right, kind of assessment. But otherwise wasn't correlated with anything, which kind of matches what I just explained on the last one. And otherwise, pretty mild correlations. So this is some work from Spencer's dissertation, actually. And I'm kind of highlighting that, you know, we use what's called a principal component analysis to identify kind of the groups within these patient-reported outcomes that seem to fit together nicely. And you can see there's kind of 5 components of well-being that are identified here. Kind of the pain and physical limitations, the psychological distress, physical activity, sleep deprivation, and pain catastrophizing. And you can see how these PROs kind of correlate to those groups of them fairly well, and how the patient-reported outcomes correlate with each other and kind of fall into these groups. I don't think that was a surprise, but some of these PROs are fairly new, and so identifying those correlations are important. So Spencer had kind of pointed out some of these, and I found some pieces here that I think are really interesting. These are just some motion parameters pulled from what we learned from our SpineSense device. And they kind of give you an intimation that maybe we've got a something here where we can start looking at, for example, my arrow didn't show, there's another arrow that points down below. It'll show up later. But there's perhaps a centralized pain phenotype that's coming out based on ways that we can observe, particularly their range of motion and their velocity of motion. Maybe helps us to identify someone whose pain is centralized. That could be an important clinical clue. Another piece here we found is that out of all our activities, perhaps the sit to stand motion is maybe the most diagnostic when you're distinguishing pain intensity from other factors. So if you're trying to weed out kind of different levels of and experiences of feeling pain from actual other types of metrics, that one may be a key. And then also there's this asymmetry in velocity of motion, which I mean by as you ascend into a motion or descend back from a motion, that difference in how fast you approach that. Are you faster going into flexion versus coming back out of it, or vice versa, actually seems to highly correlate in distinguishing pain from disability, which is also an interesting factor here. Part of this analysis was identifying phenotypes, like groups of individuals that their motion characteristics are similar between them, and what does that actually mean? And here are some of our few dominant phenotypes that we found, and we came up with names for them here, but you can basically seeing them kind of distinguished on a principal axis chart, which probably doesn't mean a lot to most of you, but essentially these are natural groupings of the way that people move based on the features of that movement. And what you're looking at here is a map of the strain fields, or the way the skin stretches along the back, which correlates to how the individual functional spinal units in the spine move. This one's one called an extension fast motion phenotype. And a couple of things that are interesting about this one is, first, that they're going all the way to full extension in about 1 second, which means they're moving really fast. And then the second is that there is not a lot of difference between left-right on this phenotype. They're moving symmetrically side to side, but asymmetrically as they go in and out of the motion. And this actually seems to correspond to one group. I'll kind of show you what that is. This is a symmetrical motion phenotype where they're doing lateral bending, and you can kind of see it looks fairly similar when they do it to the left or to the right. This is when they're looking at extension, and this is females without chronic low back pain, and they have these consistent extension motions during the first and final repetitions, and some basic characteristics of motion in different types of motion. And I'll kind of cut to the chase here, that once you've got these phenotypes, then what you can do is start to look at how do those phenotypes correlate with these patient-reported outcomes that we've found. For example, does that correlate to pain intensity or ODI or the promise pain? And you can see that for many of these, you're seeing pretty strong differences, pretty high correlations. For example, this symmetric motions phenotype here in the purple is highly distinguished from this fast extension phenotype. So if you move fast in extension, likely you're not having that significant amount of pain. And if you have this symmetrical motion phenotypes, likely you are getting significant amounts of pain. Likewise, disability, pain, physical function. Sleep deprivation did not seem to correlate to a lot of these physical metrics. That makes sense. Maybe sleep isn't affecting the way we move as much. But this idea that we can track kind of these patient-reported outcomes based on how people move is a new piece of information that we hope will end up being clinically relevant for you. Some additional studies that we've done. One was looking at paraspinal muscular fatigue. We used this same device, the SpineSense system, and we got it on a cohort of individuals before and after we fatigued their back muscles to see how easily could we identify when someone had actually fatigued their paraspinal musculature. And it turned out to be highly accurate. We can get with 84% accuracy even people who are not in our model. Right, so there's a difference between a model that's based on that, everybody that you would evaluate is already in the model and we're kind of identifying them, versus one that's generalizable to the general population. This model was only based on 20 subjects. It was the thesis work of Darcy Billmeyer, whom some of you know. And that's key because it turns out when you have paraspinal muscular fatigue, that puts you at high risk for having an acute incidence of low back pain. And so if your muscles are fatigued and you already have underlying back instability, then that's the time you're going to trigger that with fairly limited physical activity. So being able to send a push notification to somebody's phone or their watch and saying, hey, you are primed for an incident of low back pain that maybe is going to set you out for 2 weeks would be really helpful. This was a study where we were able to just say, hey, without knowing in advance, can we identify the motions that people are doing just based on the way they move their spine? For some of you, maybe that seems trivial, but for a computer, that's actually quite difficult. And we have a pretty good sense for that. We have about 92% movement accuracy. That plays into one of our studies we're currently working on, where we're collecting data from people over 48 hours of their life, where we don't know exactly what activity they're doing in advance. They're just living their life. And then we can pull out what activities are they actually doing during that time, and how does that correlate with their low back pain status and their recovery. And then just can we identify folks with chronic low back pain, and that's a pretty easy task. Here's a quick look at 48 hours of daily living. This is just kind of a, what does it look like in terms of just picking a few of these sensors and just saying, how are they moving? How is the back moving over 48 hours? And comparing that with typical data that maybe you've seen reported before, which would be something from an accelerometer worn around the waist or on the wrist. So this is data on the top and the middle from our spine sense, and in the bottom row, this is from an actigraph that's been collecting data continually at the same time, same individual. And a few things that we noticed that were kind of, aha, that was, why didn't we think of that before? One of them was that actigraph data from around your waist is not the same as spinal motion data. We often correlate those two, but they are not the same. You'll see there's a period of times here where we have the actigraph active down here, where we've got lots of step counts going on, and we've got almost no spinal motion going on. So it turns out, unless they've got, you know, some kind of music playing in their head when people are walking, they're not really moving their spine a lot. There are other times when they're not bouncing that accelerometer at all, but they are moving their spine a lot. I think of activities where they're kind of bending down to pick something up, but they're not really moving. Maybe they're even on the couch and reaching for something, I don't know. And then there's periods of time when both the actigraph and the spine sense are active. And those may be the key moments in the day when you're kind of physically active as well as bending your spine. What we think, identifying periods of time when the spine is actually engaged in motion is probably more descriptive and predictive of spine health than simply knowing when their accelerometer on their waist or their wrist is bouncing around. So kind of where we are right now, we're looking forward to our future work, which we have data now. In addition to our data, we were part of this clinical trial. It had 4 arms to that trial. And we have our spine sense data before those patients started the trial, at the midway point at 12 weeks in the trial, and at the conclusion at 24 weeks of being in the trial. So we have the opportunity now, looking at those 4 arms. One arm was looking at acceptance and commitment therapy, one was taking duloxetine, another one was using an evidence-based physical therapy protocol, and the other one was engaged in enhanced self-care, right? Encouragement to eat right and exercise and to kind of take care of themselves. And we're looking forward to not only identifying whether in advance we can see if these phenotypes correlate to how someone, you know, performs in this clinical trial, but also being able to track improvements that maybe correlate to the patient self-reported improvements in their patient-reported outcomes. So we're pretty excited about that. That data finishes its collection here this month, and so we're looking forward to that data analysis. And then I'll just give some thanks. You know, work like this takes a lot of folks. This is kind of a snapshot of the folks in our lab. It turns over periodically. At some point during this project, we've had about 80 undergraduate students involved in this work, which is pretty phenomenal. We've also had a lot of graduate students, and particularly Spencer has been kind of key in some of our analysis of this work. But thanks to my collaborators, David Fullwood and Rika Mitchell down at BYU, Spencer, Sarah Alger, Jordan Ryan, Andrew Gibbons, Paul McMullen, and Darcy Billmeyer, who've all made significant contributions to some of the data that I presented today. And with that, just thank you, and I'm happy to answer some questions. I know this is kind of rapid fire, not a lot of if this was your patient kind of questions, but I'd love to have more questions. Yeah.
Were these all non-surgical?
Yeah, so these are all non-surgical, although we have got a couple of surgical patients through Dr. Edwards' group here as well, and we look forward to kind of increasing that group to see if we can add kind of a fifth arm that has some surgical outcomes associated with it. Yeah. Other questions? Yeah.
Do you envision taking some information about how somebody's moving and then saying, based on the way you're moving, these are the suggested exercises, or this is how you how it would impact, like a physical therapist would do to improve the mechanics?
I think that's maybe in the future, getting into the specifics, but I think in the right now, what we'd like to do is, as most of you know, dealing with non-specific low back pain, especially in chronic low back pain individuals who have been experiencing this average of 7 years, is a very challenging task. And right now, the literature says that on average, almost any one of our treatments that we might pick for them has as high efficacy for a certain group, and it's usually about 30% of them. So 30% of people with chronic low back pain will respond to physical therapy in a very positive way. 30% will respond to surgery, 30% respond to a drug-based intervention, 30% will respond to enhanced self-care, 30% need to go cognitive behavioral therapy, and visiting with someone that's a pain psychologist will provide the best outcome for them. We'd really like to be able to steer them to the right provider, to say, you are going to have the highest chance of success by visiting with this provider first. And that's what we'd like to enable clinicians to have in their toolkit, is to say, let's add in motion. I'm a mechanical engineer, so to me, I look at what you guys are doing in terms of the clinical side, and it's amazing. But I pose this question: if you take somebody, and I know this isn't true for all of you, some of you are also biomechanics folks, but I pose this question, like if you take somebody who is experiencing pain when they move, and then you have them hold still and take a picture of them, an MRI or a CT image or whatever, in the position where they're not moving, where they're feeling the least amount of pain, and then you use that as your diagnostic tool. That doesn't make any sense to a mechanical engineer. Like, there's underlying structural things, but we know those aren't highly correlated to their pain. But we feel like getting motion in there as an additional factor, that's going to tilt the balance, give you another piece of information. We don't anticipate it replacing the other things that you currently use, but we do think it's an additional piece of information that is going to help.
These phenotype groups, are those assumed to be the way someone moves because of pain, or the movement pattern that created the pain?
So let me be specific. These phenotype groups are interesting because they are just based on a totally blind analysis. They're like saying, I saw 10 people walk into the room, and 3 of them moved like this, and 3 of them moved like this, and 3 of them moved like this, and one of them just moved completely different. And so I'm going to group those 3 together based on characteristic ways that they move. It's blind to the fact whether they've got pain or sleep deprivation or anything else. So one way is to just say, do those groups actually correspond to pain or sleep deprivation or something else, which is what we've presented here. But another way is to actually say, now that let's look at a clinical trial that's actually seen how they did, and then let's say, are there phenotypes of people that move a certain way that respond a certain way to a treatment? That's not a generalizable, I see them as I go in the room. It's a more specific diagnostic type phenotype, and that will be the next step for us. Great,
what about with machine learning? Because it seems like these are complicated patterns that would be hard for somebody to look at and recognize.
Yeah, you hit the nail on the head.
Where you can see the patterns beyond, where it seems like the timing is right. where that's become.
That's exactly, yeah, that's exactly what we're using here. And I didn't show you a lot of the machine learning data that we've collected, but essentially that's how we're doing the analysis of these, to say what are the characteristics of the motion that are most representative of that motion. And you hit the nail on the head. Like, machine learning is an awesome tool, relies on having lots of individuals, which is why we're so excited to have 1,300 people that we've got data from, because it allows us to now start using that large group of subjects, and not just 1,300 people, but 1,300 people doing 13 exercises for 6 repetitions each gives us a tremendous amount of data that we can now leverage. And for each of those exercises, we collect about 7 different parameters from that we use to put into our machine learning model, so that it quickly balloons into something that has some ability to determine this. Downside of machine learning models is that they're black boxes, right? So one of the pieces we hope helps us get away from the black box a little bit is tying these to physical motion phenotypes that, in terms that are obvious and communicable to other people. So, yeah.
Have you been able to, I guess I assume you have established normative motions, normative speeds,
Yeah.
and then use that data, I can see that employed in rehab if you're at real-time feedback if someone is moving, doing an exercise, saying, okay, you're engaging here, you're not moving here as well. Is that real-time data, is that something that?
Yeah, that's exactly what we're doing right now, and a little bit different maybe than you're anticipating in the physical therapy clinic. In other words, we're not saying there's a baseline that all people should move this fast, and there's the threshold, and if you're moving this fast or this fast, then you fall into a category. It really is a machine learning model, means it's taking characteristics from multiple aspects of the way they're moving. Not just speed, but also asymmetry side to side, asymmetry into and out of the exercise, recording all of that information that, it's interesting, talking to folks, physical therapists, chiropractors, often they will look at a patient, see how they're moving, and have an insight as to what may be the underlying concern. But objectively quantifying that, and in a way that we can communicate that to others, is really what we're trying to do here. And so, but essentially, you would have them put the spine sense on, it would record their data as they went through some diagnostics, upload it to the cloud, come back, and then give you a dashboard, basically how they're doing on each of these exercises. And maybe the idea would be in the future, right now we're dividing into arms, but the point would be eventually to get to the point where we could identify the best portions of the physical therapy. Like, how is it, this is a physical therapy patient, but there's a subset within physical therapy that's maybe the place where they should be engaging the most. And I think that's kind of what you're getting at.
Yeah, we use a lot of data with return to sport, ACL.
Mm-hmm.
There's a lot of ankle velocities, a lot of force plates. There's a lot of data pulling in, and it's interesting that insurance is using some of these wearables to say, oh, we don't need them to go into a clinic. They can wear this wearable at home, and someone can call in and say, okay, you're not moving your knee as much.
Yeah.
So it's interesting to see the approach of how they're using that data and leveraging it, and I hope there will be that clinical focus.
That's what.
Would be a great tool.
Yeah, that's what we're aiming for, is a clinical, a help and assistive clinical decision-making tool. Yeah, we're not looking to take the physical, the clinician out of the pathway here. Thank you. Any other questions? Thank you. Appreciate the time.